In the last 2 years, significant advances in modern surgery and anesthesia have improved patient safety, outcomes, and procedural efficiency. These developments focus on automation, monitoring, robotics, and minimally invasive techniques. Technological improvements in robotic-assisted surgery allow greater precision in complex operations, such as cardiothoracic or gastrointestinal procedures, with reduced recovery times. Enhanced imaging systems, like 3D and augmented reality guidance, now assist surgeons in complex anatomical navigation, improving outcomes. Machine learning algorithms are integrated into surgical platforms, offering predictive analytics to reduce complications. For example, AI can analyze patient data to forecast postoperative risks and recommend preventive measures. Custom implants and tissue scaffolds created via 3D printing have found increasing use, allowing personalized surgeries. This is especially beneficial in orthopedic and reconstructive procedures. Closed-loop systems monitor patients' vital signs in real time and automatically adjust anesthesia dosage, reducing human error and ensuring optimal sedation levels throughout surgeries. Advances in genomics allow anesthesiologists to tailor medication based on genetic profiles. In summary, the recent innovations in surgery and anesthesia enhance safety and precision, fostering better patient experiences. The adoption of robotics, AI, and personalized medicine represents a significant leap forward in healthcare.
We move on to our next panel, which is on modern surgery. Modern surgery cannot start without diagnostics. So we have Dr. Sri Priya, radiologist who specializes in liver radiology. May I ask Sri Priya to come on the dais. Next, I request Dr. Rupesh Kumar, who is a surgeon in this hospital, who has been part of our marvelous medicine journey. I'd like to request Dr. Suresh Babu, a senior neurosurgeon, who has been part of our marvelous medicine journey. Next, I'd like to invite Dr. Raghavendran, senior anesthesiologist. Modern surgery is not complete without the women surgeons who are, breaking down all bastions. So I'd like to invite Jayapriya. All the advances in surgery wouldn't be possible if there wasn't, a good intensive care team which looks after the patients after their complex surgery. So I'd like to invite Tejaswini Anil onto the stage, please. And to moderate the session, we will have Ilango Sethu, our resident marvelous medicine surgeon.
Thank you. Thank you, Patasar and Vidya ma'am, for this opportunity to interact with the giants in the field. Modern surgery, I really don't know what has changed over the last decade, but what I admired as an intern in 1996 and the surgery that I practice now are completely different. So I think the like they usually say, much water has flown under the bridge. So we took out, there was lots of discussion in the marvelous medicine over these 4 years in surgery, but we picked up a few topics which will be of interest to us and then give us a perspective of what we have done. So the first one is to the neurosurgeons. I do see a lot of hybrid operating theaters. I think radiology, surgery is working together, and I think that change has happened in vascular surgery and in neurosurgery. So what is your take, Suresh Babu sir first, and then Rupesh to follow?
I have not worked in a hybrid theater where there is a combination of surgery and this. One of my close friends, Dr. Sendilnathan, he had hybrid theater in private sector. I know Dr. Murali also was coming there, and we did a few cases. I took patients there and we did cases. You do an angiogram for an aneurysm, and then you decide on the table whether you need to do a clipping or coiling. Then you can decide on the table. And during surgery, suppose you do a clipping and then you have a doubt whether we did not have ICG those days. And if you want to do intraoperative confirmation that clipping has been done well, then you immediately take the patient to the stitch there and then do it and come back if there's a need to reapply the clip. So, but as of now, I don't think we are using hybrid theater in any of hospitals in Chennai. What do you think?
So the concept, what I could understand, what is that previously cardiologists, radiologists didn't do cardiac imaging. So it's always the cardiologist. Were doing cerebral angiograms conventionally. But what has realized is that the interventional part of the part, that is aneurysm, previously we used to clip a lot of aneurysms, but the shift is changing now. Hardly any aneurysms are clipped. It's more towards endovascular. People also wanted that, so they don't want a craniotomy. So the endovascular is now taking up a big way. Our country is almost halfway through. In UK, Europe, and most of the US now, hardly aneurysms are clipped. Majority of it, 90% are going for endovascular. So the neurosurgeons left out. They feel that they are becoming jobless. Neurologists were only referring these patients because the patients come to them, they refer to radiology. They also thought, why we should be sending them, let us start doing. So now the shift has changed. So neurologists have started doing angiograms. Neurosurgeons have started doing angiograms. They don't just stop by angiogram, they also do interventions. So now it is a hot field competing between three specialties: radiology, neurology, and neurosurgery. So I think that is going on now, and still we don't have an answer who will be the best in this. And so it's like a common pie. Whomever wants to take, you can take. But the younger neurosurgeons are now realizing that, and majority of them are now showing interest. So I take part in many of the young neurosurgeons forum. Their main specialty is now, anybody want to know, I want to get trained in endovascular. The problem with neurosurgeons training in endovascular is that can do diagnostic angiogram quite fast learning, but doing an intervention, it minimum takes 2 years. But neurosurgeons think that, okay, they know anatomy, so they can do, so they do very limited learning, and then they try to jump in, they burn their fingers. So it also requires 2 years dedicated training after their MCH. For that, they should stop operating. So it's a balance whether neurosurgeons, so there are neurosurgeons who call themselves a hybrid, that they do both endovascular and they do also do surgical. But for a clipping, for somebody to do clipping, it is the highest, what you say, among the grades of neurosurgery, vascular surgery is the highest. So for them to become a vascular neurosurgeon, it takes years. But for an endovascular, that learning curve is not that high. So they cannot be mastered in both. So they have to compromise on one. So this concept of hybrid things, it may evolve, but we cannot be the best in both. Either they can be good in endovascular or good in microvascular. But however, this is going to be the future.
Thank you. Thank you. So, do you see that this kind of thinking process will spill over into other surgical specialties like breast surgery and GI surgery for complex work, this hybrid data? Because I was asked this question, can you find an utility for the hybrid data when you do your complex liver surgeries?
I think vascular surgeons, they are doing not just, they are doing more of endovascular work also. So same way may apply. Example, they want to do a preoperative chemotherapy. Example, liver. So the preoperative, you want to do targeted chemotherapy intraarterial, I think they may start doing it if they learn those techniques.
We have Professor Shekhar in the audience. He does quite a bit of vascular interventions. He has left. Sorry, Dr. Murali?
Yeah, I think Dr. Rupesh put it very clearly. Hybrid theaters, yes, it is nothing. It is the same cath lab which you have to keep it in the theater. Now, what are the challenges? The first challenge is a cath lab is a fixed machine. In the theater, you want to go to a corner of the theater. Whenever you want to use it, like a CM, you have to use it. Now, why can't you use the CM itself for that? The reason is, once you go to high-end cath lab, you need a 3D angiography, you need a CT combination. You have so many things which are coming up, navigation, everything comes in. So for that, you need an isocentric CM. Still now, all the CMs in the theaters are not isocentric. Though there are certain orthopedic CMs which can do a 3D, the cath labs still, you cannot do all the 3D replications in a CM. So right now, what we have in the theater, the CMs which can do a angiography, they cannot do a 3D. So neuro things right now is very tough. But the hybrid cath labs are available. What happens is, these cath labs are gone to a corner. They have a marked area. The moment you press a button, from the corner of this thing, it will come into the center of the room, and the table will be, so that it will act like a regular cath lab. So that is called, they call it robotic. I think in India, the first one we have it in Narvi Hospital in Vellore. I've gone and seen there. They have it, the GE has got it. So why it is going to be important? Because many of the procedures we do it in, for example, I do a lot of iotic work with our cardiac surgeon. For example, they do a complex surgery, they want a wire in the true lumen. So if I come to the cath lab, do it, again go up, the surgeons don't like it. Because for all the surgeons, including sir, they will tell cath lab is a very dirty place. Because the sterility, definitely, I know that the sterility cannot be maintained like what you do it in theater. That's one reason we want to go to the theater. So once you start doing in the theater, the sterility is much better. So you need a better imaging equipment. So here in SIMS, when I used to pass the wire, we used to use the CR and also use the TE to see where the wire is. Then we pass the guide wire. So we manage it. So, but the way to go will be hybrids will be the way it is going up. And what Rupesh is saying, the turf war, it's going on across the world. My personal opinion is in future, we'll have two groups of people. One group will do surgery or intervention, other group will do only medical management. This is how medicine will evolve, maybe in 15 years from now.
Thank you. Thank you, Murali sir. So, going on to further things, I just want to stick to the controversial things. Dr. Sri Priya, this question is for you. We enjoyed your talk on ultrasound for surgeons. We feel that ultrasound, I mean, it's constantly discussed in forums that ultrasound is it's like a stethoscope. Like a stethoscope, do you feel that ultrasound skills should be transferred across all specialties, like breast surgeons doing their own breast ultrasound, liver transplant surgeons doing their own liver Dopplers, kidney surgeons doing their own? What is your take on it? I'm sure every neurosurgeon will read their own MRIs before they operate on tumors. They don't like the neuro. I do the same for my specialty. So do you think those ultrasound skills should be transferred to the individual specialties and taken off radiology completely?
I think you asked me a very controversial question, but I think whatever you have said is already happening. So neurosurgeons are doing their own because they have the clinical information, they've seen the patient. Transplant Dopplers are probably done by at least the younger generation of transplant surgeons I know are quite as good as us. In fact, they need to call us if we have to go and do the Dopplers. Otherwise, they can very well do the Dopplers. Most of the intra Dopplers, they seem to be learning it. The younger crop of surgeons. That's how I've seen it grow. Ultrasound is the surgeon's stethoscope, and that was my talk that day when I gave to learning general surgeons, because I think it's more about do you have the time to do it all the time? Because when we are sitting in radiology, we have a dedicated machine and we have the expertise as well. But I think when it comes to interpreting the findings, it's good for surgeons to know, because they first should know when you can order an ultrasound, and that would be enough rather than ask for CT for all cases. So definitely, why not? Surgeons, especially among other clinicians, surgeons should know ultrasound. But I think most of the time they won't have the time to sit and practice it. And ultrasound is something that is intensive. Even if a liver surgeon knows how to do the liver Doppler, he will only know to look at the liver and not the rest of the abdomen, because he's just not going to have the time to do it, nor the opportunity to do it. So we are sitting there doing this day in and day out. So, but I don't see any harm in, some amount of, but I just don't think surgeons will have the time to, maybe they may do a Doppler in the immediate post-op period or in the intra-op time just to see what's happening. But on a routine basis, it will still be up to the radiologist to, and these machines there is a PNDT Act, so not everybody can just pick up a probe and do it. There are regulations as to, where the ultrasound machine is installed, and even if the surgeon is not aware, I'm sure the managerial team will know that, there are some formalities to be done. So, not everybody can just buy a probe and do it or learn it and do it. But yes, I think surgeons should know the basics of ultrasound so that they know what is it, because that is the surgeon's stethoscope. It excludes major findings. It is the first modality you ask before asking for a CT. And even if it comes to CT, I see the current crop of surgeons just walk into the CT console, they discuss the findings with us, and it's a trend that I would definitely encourage, because it improves the reporting accuracy of the radiologist also. When we know what is it that the surgeons want, if we can answer that one question of yours, it makes our job much easier as well. So,
following up on that question, now Apple iOS phone is directly connected to a probe. So it's very useful for traveling surgeons. How good is the image quality, and do you think that's the game changer in the future?
I have no idea, first of all, about this Apple probe. But yes, when it comes to image interpretation, especially when it comes to ultrasound, we keep saying fasting, full bladder. And we say this for a reason, because we can miss out, even in a trauma setting. I have missed a big liver laceration just because it was, I was a trainee student at MMC then, and the stomach was distended, as it happens with most trauma cases. And I missed a segment 4 laceration. But there was hemoperitoneum, so they went ahead and did a CT. So I think there are, you can't just put a probe and then pick up a finding. We need to have specific fasting, bladder, we need to consider all this. How good is your window? Even in a post-op setting, do you have, with all the bandages, do you have a good window to pick up to look at the artery? So it's not as easy as they seem to make it out. Maybe to, look at the jugular vein and put a line, yes. But it depends on what you're looking for. And I don't think this is a one-all solution. Is what.
Thank you. Thank you very much. Sir.
For neurosurgeons, intraoperative ultrasound is a must. Because radiologists they can't you can't do the ultrasound with the intact skull. So only when you open the skull, the anatomy is so good. So we use for a lot of tumors, deep-seated tumors, we get a real-time navigation with that. So it is part of the training. In fact, the thesis taken by my postgraduate on intraoperative ultrasound, its limitations and all. So it is a must for neurosurgeons.
Thank you, sir. So the next question is about deceased donor transplantation. Professor Amalorpanathan sir is here. Yeah. Sir, I think for the audience participation, this question has to go to you. Amalorpanathan sir was the key person in bringing organ transplantation. Have we realized our dream to make transplant accessible to our people in Tamil Nadu? There was a dream of bringing transplants for organ failures in Tamil Nadu some 18 years ago, and you worked hard during that time. In these 2 decades, do you see your dream realized?
Answer is yes and no. When we started in 2008, much before deceased donor transplant took place, it was largely live donor transplant. The donors were mainly poor, the recipients were mainly very rich. The donors were women and the recipients men. Donors were young, the recipients were old. The donors were mostly from government hospitals and the recipients were mainly in private hospitals. We wanted to change this, and this is why we started a government-run cadaver transplant program, and we gave a special incentive to hospitals, government hospitals, to do transplants, giving extra marks to the donor list, recipient list, etc. Did it change much? In kidney transplants, to some extent, yes. Today, even every medical college, almost, we have 31 medical colleges, around 18 to 19 medical colleges do kidney transplants, free of cost to the poor people, with very good results. So that way I am satisfied. But did it go to other transplants? Again, the answer is yes and no. In government, we had a lot of hopes that government medical college will do a large number because it had a separate hepatobiliary liver department in government Stanley Hospital. So we also had an MOU with private hospital, thinking that the world's famous surgeons will come and help the government doctors there, and the transplant program will go up like any other sector. It didn't happen. 8 years down the line, it didn't happen. Again, we tried the same thing now with the MOU with Madras Medical College. About 18 to 20 transplants are done. It remains to be seen whether it will continue. But the other point is, even if a poor patient wants to have a transplant in Tamil Nadu, he can still go to a private hospital because Chief Minister's insurance scheme gives up to 20 lakhs now. You will know that better. So a poor patient is not all that left in the lurch today. He can still go to a good liver transplant center and have the transplant where the government bears the cost, almost say 70-80%. This is true of heart and lung also, that most of the poor patients can still go to a private sector and get them done by government's insurance scheme. In liver, this is going on well, but in heart and lung, first of all, many poor patients don't even reach a government hospital in the stage of failure where they can be supported for several months to wait for cadaver. And supporting them is a very, very heroic task, as you know. And lung transplants require very complex immune suppression, and most of them succumb. So I wonder whether we should subject them to such complex surgery at this point of time at all. I may be wrong, may be crude, but especially when it comes to lung, I'm very apprehensive about poor patient being subject to that. And then he dies 10 days later or 15 days later or 1 month later. Having said that, as I said, my answer is yes and no. In kidneys, now the government hospitals have opened up very well. Many poor people can go to government hospitals, wait for their organs and get high quality kidney transplant. I'm waiting for a day when this will happen to other organs. Thank you.
Thank you, sir. Thank you. To Dr. Raghavendran, I have two controversial questions. You have decades of experience in interacting with surgeons. My question to you is, should perioperative medicine be given to an internist, that a physician, or should it be managed by an anesthesiologist?
Well, I'm quite fortunate to be working with surgeons who have a lot of impose or trust in us actually. So smooth period all along, no problem at all. Well, anesthesia is evolving. Now, our support to the surgeons is not only from the anesthesia part, but also the preparation phase. And the preparation phase means able to recognize the complications or the patient disease pattern, and then do something to sort of improve the condition of the patient, get the patient to the maximum what you can optimize position, and then only subject him to surgical procedures. So this is where the emphasis is going on now. So just not only a technical job of giving anesthesia on the table, but we interact with the patients, establish a rapport, know the problems, and then optimize them, and have a sort of a very good estimation of the disease condition and preparation adequately. Interact with other physicians who is necessary, and then take them for surgical procedure. And a perioperative medicine is evolving, and many anesthetists are actually being prepared for that area actually. So you don't have to sometimes, you can definitely recognize the common disease patterns, the ECG patterns. You can make a diagnosis beforehand. You yourself can sort of categorize patients, which one to go for a special consultations, or some of them we can sort of optimize ourselves. See, even knowledge of diabetes, knowledge of coronary disease, even kidney functions. Now we can have our own assessments and all, and that will really come handy. So we are actually devoting a lot of time towards the patient preparation before surgical operation itself. So perioperative medicine is definitely evolving, and we are really playing a crucial role in that also. And not only that, it just doesn't stop with the surgical period. Again, post-op. So we just sort of take care of the patient's condition, patient's well-being post-op, whether it is pain or optimization of fluids or acid-base status, everything, and then determining when they can have to go to surgical wards or go to ICU, everything. So, and most of the times, the diabetic management on the table and immediate post-op is by the anesthesiologist. So we have to have a very good understanding about medicine, and also that is something like acute care medicine. And we are also sort of involved in the emergency care. Many times we call us not only for pain, but also for fluid therapies and for lines and other things now. So our care is extending before, during, and after. So the scope is definitely improving, and I think that's how we are able to sort of establishing ourselves as one very important a specialty which is going to make a difference in the outcome.
Thank you, sir. Thank you. As a surgeon, I have one generic question. How do I actually gain the anesthesiologist's trust?
That's there's both ways, no? Okay. So trust is actually, which builds up over a period of time, not immediately, no? But actually, you by certain gestures and by deeds and the way you manage things, the surgeons will definitely form initial opinion, and later that will get consolidated over a period of time. It doesn't build up just by doing one case, no? So
Yeah.
you have to be there and then show the results. How and how and when these things trust develops, it's a matter of conjecture. No, it will take some time. Sometimes I think good people like to see the moment. I think he chose me about some 32 years ago, based upon the impressions which he had from other people. Okay, but sometimes no, and same thing, Dr. Ramdas also. I did one case with him because Dr. Naidu that day was not available. They called me, and that day onwards, I became his anesthetist. So the trust built up within a short time with one case itself, but sometimes over a period of time.
Sir, if I can add a point here, you anesthetize patients for good surgeons, you anesthetize patients with bad surgeons also. But when we come as surgeons, we decide that. How can you do that? It's like sleeping with the enemy.
It's inevitable, no? Well, we know how to sort of escape certain, find escape. Okay,
Sir,
so
please.
In a private setups, usually, we are quite safe, no? Sense that whoever comes, they are quite competent above a particular level.
Shall I respond? See, we anesthetize patients, not the surgeons. Okay, that's the first thing. Whether they have a trust or not, we anesthetize patients, we look at them, what is the problem, what is the thing to be tackled. That is what we address, and then we do that. So whoever is operating on the other side, that is his problem. And sometimes we involve ourselves in correcting them if we have the expertise to say that no, this is not okay. At least I do that. I do not know. And so we don't qualify them as a good surgeon or a bad surgeon, but does he take adequate time? Does he take proper precautions, and does he take care of the patients post-operatively? That is what we look at to say whether the surgeon is good or what otherwise. If a person comes, operates, and goes off, and somebody looks after, I don't consider them as very good. That's what it is.
Thank you, sir. Thank you.
Question to the anesthesiologist. I'm a general surgeon. So there are instances in my life that I've refused to work with a particular anesthetist because I found it is not safe for my patient. So have you as anesthesiologist refused to work with a surgeon because you considered them unsafe?
Yes, I have. For my side, I have. Because I'm not in the private sector and I've been working in a medical college. So straight point blank, I have told I'm not going to work with you because this reason, and I reported that I'm not going to work. Don't compel me to go there. So that I have done it. But not many people can do that because of the situation and of the environment in which they are working. But I have done it. That's all I can say.
Dr. Lalit, you can go.
I'm a student of Sir, and I'm an anesthesiologist. In the National Health Service in UK, there are 3 A's: affability, ability, and availability. So surgeon will look at, is he able, is he available, and is he this thing. In private practice, the 3 A's are availability, availability, and availability. So that's how it is.
Thank you. Thank you.
This is a general doubt. I want to know, like, suppose a patient is not rich enough to go for a transplant, like for any treatment which is going to be costly, like for a liver transplant, anywhere around 50 lakhs, to my knowledge, will cost. Someone is not rich enough to pay that 50 lakhs, but he is not poor enough to go. I don't know where the limit is set for going for chief minister's health insurance, like because based on income basis only they give that certificate, like Kalinga insurance or whatever insurance it is, like So somebody in between these two, not rich enough to go to private, or like they cannot get the government insurance, like because they are not that poor also. So do they have any other this thing? That's what I want to know.
That is one of the challenges that is actually remaining. We see a lot of
Because
people.
I feel after retiring, I will fit into it. I don't have a pension. Okay, I have to be very frank. See, I don't have a pension. I never worked in a government setup. So if I don't have money, then like I will be there. Like I'm neither rich nor poor. Like then where I go? Like because when I was a student, anybody can just walk into a government hospital and they can get the treatment. Like that was the thing when I was a student. Like yeah, there is no like income based or anything. Nothing was a criteria. Like so really, I want to know, like, for many people ask this question, like,
So
somebody in between, what is the thing for them?
I think we can discuss this in Marvelous Medicine in detail on one particular thing.
Okay.
Yeah, just one thing. You talked about trust. How do I transfer the trust? Or how do I trust an anesthesiologist? See and about the perioperative medicine. Actually, for more than about 15 years, I have been talking about anesthesia department being renamed as the Department of Perioperative Medicine and Pain Management. That is how it should actually be. And people should be trained to look at the patients right from the time they start coming into the hospital, manage them, and anesthesia only part of it. It is not the soul. And see them off and out. Right? That is what should be the thing of perioperative medicine. But to find that so much advancement has taken place in every specialty, for one person to know everything is not possible. So again, this person has to get compartmentalized to few specialties like that. Then I said that is not going to be happening in the near future. Thank you.
Thank you, sir.
Ilango,
Amal,
just
Amal, sir, you
to-
can follow up on the cost. Yeah.
This is for the clarification of Madam. So, incidentally, Tamil Nadu government was running Chief Minister's insurance scheme for about 10 years or so, and they recently appointed a committee to study its functioning, and I was one of the members of that committee, and we recently submitted a report. So, see, government is spending around 2,300 crores annually to cover the poor patients of the state for a variety of illnesses, about 140, 150, I forget the numbers. And if you want to increase the number of patients, you will have to increase the premium, or you will have to increase the budgetary allocation too, both of which is not possible at present. All through this country, every state, the health budget is either stagnant or relatively decreasing. It's not at all increasing. This is a fact of life. So this problem is genuine. Whereas poor patients are covered with the CM's insurance, rich patients can have their own packages running to crores sometimes. So where do the people in between go? So we have suggested, I shouldn't be talking about the report myself, but we have specifically suggested that people who are not below the poverty line, but who want to take CM insurance scheme at a slightly higher premium. See, today government is paying around 800 rupees per head for this coverage. Supposing people are able to pay say 1,000 or 1,200, the insurance must accept that and include them into CM's insurance scheme and extend them all the coverages that are available for other poor people. But the insurance companies are resisting because they lose out. Their logic is we can't have two different packages, one for government and one for private, because everybody will shift here. So we will be losing out. So it's a very tough game, and we are trying to negotiate with the government and with the insurance companies. We are literally actually arm twisting them to accept that. If they accept that vast majority of middle class will be covered by the insurance scheme, that will be good for both.
Thank you, sir. Thank you, sir. I think.
Thank you, ma'am. Thanks, everyone. So, from my perspective, I think the patient just comes for surgery. So, anesthetist has to be kind to the surgeon and then look after the patient, because patient will not come just for anesthesia. So, from what I have learned, at least my teachers, anesthesia teachers, they have all taught me that. And I tried to apply the same principle when I moved into intensive care. And I found it doesn't work, because what used to happen was surgeons would operate, and then in abroad, at least in Australia, in public hospitals, surgeons want to learn. So they would operate, they would do everything and get the patient to ICU and leave and go. So it would be our headache to counsel the patients, explain what would have happened. So the relationship possibly wasn't that great when I moved to intensive care, because I always used to think patient comes for surgery, so anesthetists have to ensure that they have a good rapport with the surgeon and work with them to ensure that the patient gets better. But after moving to intensive care in a public health setup in Australia, I learned, okay, no, you can't just blindfoldedly believe that whatever the surgeon does is good for the patient. So there are times wherein we have put our foot down and said, this surgery shouldn't have happened. You guys have done it, but we are going to tell the patients, you will stay with us. We will both counsel together as to why this was done and how we are going to settle it. So I think my perspective changed a bit, but I still consider that patients will come to the hospital for the surgeon and anesthetist has to abide by the surgeon.
Since you worked in India and in abroad, so there is a lot of hype about ERAS. So my question is ERAS about the patient or is it about the money that is spent on the patient by the insurance company? I think Dr. Biju is here. Yeah, I need some support from the surgical side.
Honestly, sir, from what I have experienced, especially in the intensive care setup in a public hospital, ERAS early recovery is something that as intensivist all of us support, because main thing is if the patient walks, it is better for the patient. If the patient walks early after surgery, and having been through some very complex surgeries myself and having been in the ICU as a patient in the same ICU where I was working, I realized that I recovered much faster when they gave me all these blocks, when I had an epidural, when they gave erector spinae blocks. So I would definitely advocate that for my patients. I want my ICU patients walking. I don't want them lying down, end up with atelectasis, pneumonia, and then go back on ventilator after surgery. I want whatever anesthetist wants to do, I'm happy with that. I will fight with the insurance companies, I will fight with whoever is necessary, because at the end of the day, I want my patient up, about, eating, walking, not complaining of pain. Of course, pain threshold is in India is much lesser than what it is in Australia for patients. But then I feel that pain management, at least from my practice, what I've seen in India versus abroad, proactively tackling pain and ensuring that we do all these blocks and everything to ensure that the patient mobilizes faster. For me, it is very important because every ICU bed, I'm keeping a painful patient only for pain management. I'm taking away that bed from a patient who might be having ARDS and who might be sitting in emergency waiting for an ICU bed. So for me, I look at that perspective. And at the end of the day, whether it is in ICU or outside, I think early mobility is good for the patient. They need to eat up. So everything, whatever needs to be done for early recovery after surgery, we should do it. That is what I believe. Yes.
So it's not about the number of days the patient spends in the hospital. See, for example, a lap colectomy or a Whipple's resection. The normal stay during my training days was 14 days. Now we try to send them on the 5th day. There are some people who send it earlier abroad. So I've seen total pancreatectomy patients sent home much earlier. Daycare surgery for lap cholecystectomy has become standard. So is it about the money that is spent by the insurance to ensure that the patient gets out of the hospital so that the funding is limited? Or if you take out the question of money, will you keep the patient till they become confident to move on their own? Dr. Biju, I think, also can add up.
Way forward is we put all our effort starting from the surgery or fixing more surgery. It's better that don't rush for surgery. We have gone beyond rush. Okay, we have gone to more rehabilitation. Make them fit walking before surgery. Do the surgery as a small step. Try to do it as a smaller step, and they will walk. This is the message we have to convey. All the trials, whatever we are doing, we put hundreds of trials post-operative. So it's better to put all our effort pre-operative and make them walk. your question regarding insurance, after colectomy, Japanese patients go after 14 days. Okay. Near zero mortality, less than 7% of complications. The reason is insurance and other cost. So our hospital and peri-hospital environment stay, we put it that way. You might be discharging your patient, but I might be discharging, but are they staying outside the lodge or some? So the peri-hospital environment stay has to be considered as the stay under the medical supervision. So if you in the cost benefit analysis, whether we could be able to reduce that is a significant. The way forward is critical is prehabilitation. Go forward, go beyond eras, execute in a set of micro environment. It is going to work.
So you are used to a lot of robotic surgeries and minimally invasive surgery. So, and we are constantly, as surgeons, we are pushing the boundaries. We are doing more extensive resections, more complicated patients, and like Sun Tzu says, the good general does not fight the war; he avoids the war. As surgeons, are we tending to do more surgeries when we should be doing less? What is your perspective? Professor Sridhar also can contribute on this. I'll repeat it, sir. So, as good surgeons, we have to do less and less surgeries. I think trying to prevent them from going through that surgical issues. But nowadays, we are pushing the boundaries towards more extensive surgeries and taking more complex patients. I just wanted both your take on that.
So we have a bad idea that we have improved ourselves. No. Why we are doing safe surgery? Because of safe anesthesia, safe critical care. That's a fact. Blood bank support, whatever. If you would have got this one, the same support 20 years back, we would have done the same surgery. You know that we hardly ever mention any trials in our surgical forum. We just sleep off that time. So we have never improved this surgery. Now what we are witnessing is engineers are improving the medicine. That is what is happening now. It's not we are improving it. Engineers are improving the medicine. The fact that I'm a PhD guide, my PhD students, 2 of them are engineers sitting. My research work is on radiology. Okay, so how I am forced to do it at this era because I work on AI. I'm no more interested in doing a research in surgery because it's not going to transform anything. We are totally out of the football field if you start doing it. So we have to realize that those who are transformed us are not within, outside. Now, what is the information I'm trying to communicate to you is human body is saying we started seeing celiac axis from the beginning. Now, you know that even if you injure anything, aorta, you have salvage mechanism to do it. We knew aortic anatomy well before. That's why we are doing it. It's not because randomized trials are paraortic lymphadenectomy. No, that's not. Because you are safe and we have reached the limit of surgery, the human body. We are venturing everywhere. So it is going to improve. We are going to be more radical irrespective of the improvement in chemotherapy. We are going to be more radical. And we are not going to stop short of the radicality surgery because of the evidence under. But how we are doing it because the support from radiology, the support from anesthesia. That's why we have transformed, not by ourselves.
Thank you.
Sorry, I missed it actually. I had a call. Sorry.
So the question is, should surgeons try to avoid the surgery? I mean, avoid means do a better non-surgical care or continue to do more extensive surgeries was my question.
No, I think, I don't know about the question itself in the sense, if it has to be done, surgery has to be done. I don't think there is a question of whether we must avoid it into a rather a conservative approach. Or
so I'll put it straight. It's like morbid obesity. There are quite a bit of bariatric surgeons around. Do you feel that we are doing more bariatric surgery than we should be talking about diet and other healthy lifestyles? That makes it simpler.
Yeah, I think you must prepare him well for the bariatric surgery rather than say that I won't do bariatric. As a matter of fact, as a plastic surgeon, I don't see that many bariatric surgeries being done here. Otherwise, I would have had enough of circumferential reductions. We don't get it. So I'm not sure whether that much of bariatric surgery is being done.
Can
I don't think Radha will answer this question. I think he refuses bariatric surgery unless they prepare and come. They lose some weight with diet, etc. I don't think he just goes around operating on most of the obese.
Can I answer that?
Yeah, JP, take it.
See, I'm 20 years into surgery, starting from my PG now, and as a surgeon, my indications for surgery are narrowing down. Not because I'm not competent or I'm not trained, because I'm able to see a broader perspective now. And in the past couple of years, I'm exploring lifestyle medicine as well as a whole food plant-based diet. And majority of the ailments we're discussing in this forum, like coronary artery disease or diabetes or stroke, or majority of them are preventable and in fact treatable with lifestyle modifications. We are talking of cutting edge engineering technology, and we think we are doing super work, but we are actually failing our population who trust us. It is the responsibility of every doctor to advise the population, in fact, follow himself or herself, those lifestyle modifications that are required to prevent the disease in the first place. So coming back to surgery, for example, I'm a general surgeon, hemorrhoids. It's a very simple, stupid surgery given to the lowest rank in the unit. Somebody who's hated in the unit gets to scrub for hemorrhoids. So now, because me being a lady and I see a lot of lady patients, no one wants to see lady bottoms. So they say bottom surgeon. So given off the patients to me, what I see in my practice now is majority of hemorrhoids can be managed conservatively. I rarely operate, maybe 2 hemorrhoids in the past 1 year, primarily because they're actively bleeding, hemoglobin is less, where it has to be done. So absolute indications for surgery, the emergencies have to be done to save somebody's life, whereas majority of relative indications, when a patient is sitting across on a table and talking to you, they are good. So many times we don't take their decision into consideration. For example, I'm going to do a radical surgery for a malignancy, for example. Does the patient know the radicality? Does the patient know the quality of life after surgery? Does he or she really want to undergo? We keep them at dark most of the times. We just say, if we do this major surgery, you'll be cured of your cancer. That's what we say. They don't know what to look forward to. They're blind. Very few surgeons, actually, if you sit across and explain the complications of a lap chole, how many lap choles can we do? How many of us discuss bile duct injuries? How many of us say that these are my complication rates? How many of us are true to ourselves? So I'm with you when I'm saying that my indications for surgery have narrowed down. And I'm very, very honest. And this, I feel satisfied as a surgeon. I don't do that many numbers now, but I'm true to that one patient. I'm not, someone told me, a senior cardiologist told me that your loyalty is not to an institution or to a boss. Your loyalty is to that particular patient who's sitting with you in the OPD.
Thank you. Thank you.
Just a minute. I think it is a continuation of what you said. It's an evolution, I think. There were no other options available for hemorrhoids those days, and now there are available options. So, for example, I started my practice as a general surgeon doing minimum 3 GJ vagotomies a day. We don't see that mainly because of the physicians now treating. I don't think peptic ulcers are ever treated by a surgeon nowadays. So it's actually a disappearing thing. But the question I thought was, supposing a thing is required to be surgery to be done, and you try to avoid, is that the way?
No. It was about the one we were talking about. Like peptic ulcer changed over decades.
Over decades.
Today we have, I also see the other side. A lot of PPIs are being given, and we had a discussion about this. We are seeing a lot of neuroendocrine tumors coming up now. That means there is still an abuse. Okay, I think we'll come to the last question. This is so taking on this awareness, you also do a lot of breast surgery. So how do you think the women are actually aware, and what's the impact of breast cancer awareness, and how many women actually go through a screening program for breast cancer as recommended by the guidelines?
Okay, so disclaimer, I'm not a breast cancer surgeon. I do see breast lumps in my OPD. I mean, every other patient is somebody with a breast lump. So I research it, or I follow it up until diagnosis, and I offer it to somebody who's better than me who can do a good breast cancer treatment. So, but awareness is there. There's no lack of awareness among women. Some mild pain, pre-period breast engorgement, they come for a checkup. So they're quite aware. From youngest to oldest, everybody is aware. The only problem is I'm not aware of any screening program that is available in our country. I really don't know. But the awareness among clinicians is not there, because my practice is based on referrals from gynecologists. So they pick up a breast lump and then send the patient to me to see if it's malignant or not. Majority of gynecologists don't know when to do an ultrasound mammo, when to do an X-ray mammo. Nobody knows. And there are a lot of clinics and gynecologists or general medicine people who refer to me don't know when a biopsy is required. And there are times when a gynecologist called me and said, Dr. Jayapriya, Friday morning, excision biopsy, please come to theatre. For what? I have to see the patient first and see if the patient requires a biopsy or not. An excision biopsy era is gone, bygone. Nobody does excision biopsies to make a diagnosis these days. So awareness is there, but not among clinicians. I think we need to educate our general surgeons, our gynecologists, our general practitioners to deal with the breast and most neglected. And I'm talking about practice in the capital of Tamil Nadu.
Actually, like you've said, but screening programs are there because as a radiologist, I shouldn't be sitting right. Mammograms. If I could ask in this forum, how many of the ladies here have last had a mammogram? I don't want fingers to go up, but it would be I don't think it would be a big number. Reasons being, we think why, we think pain, but screening mammogram after 45, we have breast radiology itself is, we have enough breast radiologists in Chennai itself. They are the best people to guide us. And like you say, if clinicians who are not aware, just refer your patients to a breast radiologist. I'm not a breast radiologist. When I had a mammo and I said, okay, all is fine, can I just see you after 5 years? She said, no, you have to come back next year for the same mammo. And I said, why? She said, you're after 45. You have to have it every year. If this was NHS, they'd send you a reminder. At least I don't know if they do it now, but they used to send. Not sure of the waiting times now. But I think if we don't know, best we refer to a breast. I mean, all these master health checkups have a mammogram, a screening mammo. At least I see this group after 45 years, we should have it yearly. It picks up things and it's done by the right persons. Like you say, they will tell you. She does the ultrasound, she does the mammo. She is able to tell whether you need to come back in 6 months, in 3 months, or you come back next year. So we have the specialists and I think we should make use of them. Please go for mammograms. They are not painful. The techniques have advanced so much. There is no pain. I remember once 10 years ago or 5 years ago when it really brought tears to my eyes. And I said, I'm never going to have this procedure. It really hurts. But now the radiographers themselves are trained better by the breast radiologists to give just sufficient compression. So it's not as bad as it looks. And I think if we go to the right people, now I wouldn't hesitate going for my next mammo because I know it doesn't hurt as much. So it's just referring to the right people at the right time.
Thank you. Because I had this question for a long time because none of the women in my family ever went for a mammogram till one of our classmates developed breast cancer. So then everybody in the team, they just went ahead and got the mammogram. So I think the message is that it's there in the public forum, but I think on practice basis, women are still hesitant to go through a mammogram, and that's what I wanted to highlight. Thank you all for being here. It was wonderful interacting with you all. It was good to have everyone, and I learned quite a lot from all of you. Thank you.